Thank you so much for your kind introduction. Very good evening, my professional colleagues. This is Dr. Sepuri Krishna Mohan. So, I am an endocrinologist at my own center, Sepuri Diabetes and Endocrine Center, Kurnool. So, today we are going to talk about a very important the topic, that is the challenges we face in insulin, either initiation or intensification or titration, regarding the truths. So today our topic is the real world insulin challenges, cases that speak the truth. And today we are going to talk about the intensification of insulin and titration of insulin and management of hypoglycemia, which create the daily challenges in our day-to-day diabetes care OPD. So these are all the barriers. The first is the intensification barrier and the titration struggles and the hypoglycemia concerns. These are all the barriers which apprehend a physician to some extent not to initiate insulin. First of all, coming to the intensification barriers, this is clinical inertia. Maybe sometimes not only the clinical inertia, it is patient inertia also, for the fear the delay timely insulin adjustments and the titration struggles. Patients often misunderstand the dose adjustment protocols and the hypoglycemia concerns, because the usual side effects of insulin are only two, the bottle insulins. One is hypoglycemia, second is weight gain. So many patients under report the episodes which hinders the management of diabetes. These case-based insights will enhance your clinical decision making for better patient outcomes. So today what we do is we go by cases, a series of cases, like we have taken some 6 cases. So we'll go according to the case-based approach today. So the number 1 case is, it is a case of the type 2 diabetes, the initiation of basal insulin in type 2 diabetes. It's on a rural case study. This case study examines a 45-year-old farmer with poorly controlled diabetes, type 2 diabetes, despite the maximum oral medication, and with an A1C of 9.1% and persistent hyperglycemia. The patient required insulin therapy, but he has showed reluctance due to the fear of injections, cost concerns, and the social stigma. These are all the problems associated in a rural setup actually. It's not only the fear of injections, the cost concerns, and it's a taboo, like something like the social stigma, which is otherwise called the taboo. So we'll explore how healthcare providers successfully initiated basal insulin therapy in the resource limited rural setting, addressing the patient's concerns while improving the glycemic control without causing hypoglycemia. The case demonstrates practical approaches to the insulin initiation, patient education, and monitoring in challenging the environment. So this patient has got some the patient profile as well as the diagnostic parameters. The patient background, 45 years, we have already talked, a farmer with type 2 diabetes for the last 8 years. Diagnosed in his mid 30s, currently overweight, BMI is 28, with hypertension, that is the comorbidity, managed by losartan. And the current treatment is, he is on metformin 1000 mg twice a day and glimepiride 4 mg twice a day. So he is on the maximal dose of metformin, that is 2 grams a day, and the maximal dose of glimepiride, that is 8 mg a day, in 2 divided doses, and he is on losartan for his hypertension 50 mg daily, and no insulin therapy yet, despite the poor glycemic control. In fact, this patient badly requires insulin, but is not initiated, maybe because of the doctor's inertia or because of the patient inertia. According to the guidelines given by the American Diabetes Association or the American the Association for the Clinical Endocrinologists or the American College of Endocrinology, see the A1C is around or more than 9. It is an indication for initiation of insulin with existing OHS or without that. That depends on the clinical scenario and depends on the doctor's discretion actually. So this patient has got 9.1 uncontrolled diabetes, so he badly requires insulin. So there are several methods of initiation of insulin, that is to start with a basal insulin or basal plus or the biphasic premixed human insulins or the analog insulins or the co-formulations, and the basal bolus is the ultimate. So the glycemic status is A1C is 9.1, fasting plasma glucose is around 160 mg per deciliter, and postprandial is around 250 mg per deciliter, and in infrequent self-monitoring showing consistently elevated levels. See, this is main the drawback in our the day-to-day diabetes care practice is that majority of the urban or the educated, the learned population also, they don't want to go for SMBC, which is very, very crucial in the management of the type 2 diabetes or type 1 diabetes or GDM, whatever you take. Diabetes means self-monitoring of blood glucose is very crucial. That is not done properly. So this is a rural setup. Usually they don't have the glucometers, and you should teach the patient. You should make the patient learn how to use the glucometer, the precautions and all, how to take the strip and how to insert it and how to take the capillary blood and all. So it hardly takes around 5 to 10 minutes for the patient to educate. So the laboratory results and the clinical challenges. The kidney function is normal and the liver enzymes are almost normal. The lipid profile is little bit distorted. The total cholesterol 210 and LDL bad cholesterol is 130, which is not at all acceptable. And HDL is 38 instead of 40. And because male it should be more than 40 and females it should be more than 50. And triglycerides instead of 150 it is 180, marginally elevated. And electrolytes are within the normal range. And then the primary clinical challenge was persistent hyperglycemia despite maximum tolerated oral medications. The patient's A1C level remained at they remained at 9% with consistently higher glucose levels, indicating inadequate control with current therapy. The additional challenges included the patient's insulin hesitancy due to the fear of injections, concerns about the cost and the social stigma. The implementing insulin therapy is a resource limited rural setting, required addressing these barriers while developing a regime that would improve the control without causing hypoglycemia. See, usually we start in this setup. The once a day insulin, that is the basal insulin, is the best. Maybe it is you can if the patient is not able to afford to go for all these analogs and all the costlier the basal insulins like the Glargine or the U100 or Glargine U300 or the Degludec and all, the Levemir, which is the Detimir. So you can as well go for the NPH, a simple bottle insulin, which is the basal insulin actually, but it has to be given twice at least because it lasts for 12 to 15 hours only. It doesn't last for the 24 hours. So in this scenario, so the management strategy and the insulin initiation, the basal insulin selection, the human NPH insulin at bedtime was chosen as the initial therapy. It is something like something is better than nothing. Instead of twice a day NPH, we at least try to convince the patient to take one time bedtime insulin, that is NPH, which is very cheap actually, around 170, 180 max, 185 rupees. The bedtime was chosen to be the initial therapy based on the guidelines recommendations for patients with A1C above the target despite the oral medications. And the one more thing I would like to remind you that we generally we think of this particular insulin after 3 OADs. The patient is already on 2 OADs. He is on glimepiride 8 milligram and metformin 2 grams. There is an option for either SGLT2 inhibitor or something else. It can be added actually, but as the A1C is on the higher side, we chose this patient for this basal insulin regime actually. So the starting dose calculation, initial dose of 10 units of NPH, whatever be the basal insulin, you just start with the 10 milligram. Let it be a human insulin, basal human insulin, or the analog basal insulin. So 10 units of NPH at night, approximately 0.1 to 0.2 units per kilogram body weight of 24 hours was prescribed as the conservative basal insulin smarter dose consistent with the standard protocols to minimize the hypoglycemia risk. And the oral medication adjustment, metformin was continued at the same dose. Hello, please can you mute yourself, please? Yeah, metformin was continued at the same dose, that is 2 grams a day in 2 divided doses to maintain the insulin sensitivity, because metformin is a very good insulin sensitizer. Actually, it reduces the insulin resistance. While glimepiride was reduced to 2 milligram twice a day to minimize the risk of hypoglycemia once insulin therapy began. You should keep all these points in view before you initiate an insulin so that the patient will not get into hypoglycemia. So if it is 4 plus 4, 8 milligram, there is every chance of the patient getting into hypoglycemia. But usually basal insulin will not let the patient down with hypoglycemia. But as a precaution, they have reduced it to the 2 milligram twice a day, that is 4 milligram, the half maximal dose. And they started 10 units of the basal insulin NPH. And the titration plan, and it is self-monitoring. The patient was taught to check fasting glucose every 2 to 3 days using a glucometer with emphasis on consistent morning readings actually. Because basal insulin basically it reduces the fasting plasma glucose, and the funda is that 3 F's, always remember F. Fix the fasting first, then you will be able to catch up the postprandial. So all the time try to fix the fasting first. So this patient was advised to monitor the morning readings, and dose adjustment, increase the nightly NPH dose by 2 units every 3 to 4 days until the fasting glucose reaches the 130 milligram per deciliter, or until they limited by hypoglycemia. The patient gets into hypoglycemia, you stop there, or else it should be around 100 to 130 milligram the fasting plasma glucose according to the recommendations by the American Diabetes Association. The family involvement, the family members were included in education, because that is the essential part. Unless there is involvement of the family members, no patient can have a success. Not only the diabetes treatment, whatever it may be, you take the comorbidities like the hypertension, or the dyslipidemia, or the heart attacks, or the strokes, whatever it may be, the management of cancer, everything that needs the involvement of the family members. So the injection technique, it was demonstrated using the insulin pen to reduce anxiety about the pain, which guidance on proper storage and the site rotation. Site rotation is very, very important to avoid the insulin, the side effects of two side effects of insulin on the fat, that is insulin atrophy or insulin hypertrophy. That is, you find some pits if you don't change the site. That is, inch by inch you should change. Or you find lumps actually. That is called the insulin hypertrophy. So, addressing the barriers to insulin therapy, the first is the fear of infection injections, and the cost concerns, and the social stigma, and the storage issues, as we discussed. These are all the common things. And treatment outcomes, 9-point A1C was the initial A1C, and the 7.6 was the A1C after 3 months. The final insulin dose of the NPH at bedtime was 18 units, and the fasting plasma glucose was 130. So half the work is done. So all the time we need to target the glycemic triad, that is the fasting plasma glucose and the postprandial plasma glucose, 2-hour postprandial plasma glucose, and the HbA1c. This is called the glycemic triad. So he has achieved almost the 7.6 is reasonably good when compared to 9.1, and 130 milligram of deciliter of fasting plasma glucose is as good as 100. Okay. And key takeaways for the clinical practice: timely insulin initiation, and start when HbA1c is persistently more than 8.5 to 9 despite the oral therapy, and the comprehensive education address the fears, demonstrate the techniques, and involve the family. See, the take home message is insulin only can reduce the glucotoxicity. That is the fundamental dictum. That is the simple titration protocol and significant clinical practice. So these are the take home messages for clinical practice. And coming to the case, another case, second case, the intensifying to basal bolus for advanced type 2 diabetes mellitus. The case study of a 54-year-old female with poorly controlled type 2 diabetes will explore the transition from basal insulin to basal bolus insulin. So when we try the basal, it is not successful at all, and the maximal dose, you remember, it is, any basal insulin not to cross 40 units a day. Let it be the NPH, or let it be the Glargine U100, Glargine U300, or the Detimer, or the Deglutec. The maximum dose is 40. Even you go beyond 40, like 50, 60, 70, 80, it's of no use. It's wasting the insulin, that's all, wasting the resources. You should come to a conclusion that when the patient is on 40 units of basal insulin, still his blood sugars are not up to the mark, and the A1C is not to the point. It's all the time you should go from basal insulin to basal bolus, or to biphasic premixed, either human insulins or the analog insulins. And the patient profile, 54-year-old female with semi-urban town with 12 years duration of type 2 diabetes history, and A1C is 10.6, fasting is around 180, and post lunch is around 280 to 300, and she is on metformin, basal insulin, carbos, and amlodipine for hypertension. So she is already on the Glargine 20 units. Okay. Lifestyle challenges: runs a small shop with irregular meals, limited activity due to neuropathic pain. So this is the right case for a transition from the basal insulin to basal bolus insulin. The clinical challenge is the persistent hyperglycemia and the lifestyle complications. The management strategy is stepwise intensification, insulin regime changes, and the titration monitoring, and the education. The basal bolus implementation is the initial change, and 2 weeks later, and 1 month later, and 4 months later. And the outcomes and the adjustments. The glycemic improvement was there. From 10.6 it has come down to 8.2 over 4 months. And the fasting plasma glucose now averages around 130 milligram per deciliter. Hypoglycemia management, they experienced mild hypoglycemia initially, adjusted the lunch insulin and they added afternoon snack to prevent recurrence. See, whenever you are going for a basal bolus insulin or whenever you are using a secretagogue, all the time make it a point to ask the patient to have the early morning snack or the mid morning snack and the evening snack and the late night snack apart from the three major meal. That's what. Even simple 1 cup of coffee, 100 ml of coffee or tea or milk is considered a meal. It doesn't mean that we need to eat and then that only is called meal. No, that's not the correct definition of meal. Anything you take is a meal. The symptom relief and the self-management skills. And the treatment comparison, the basal bolus and the premixed are the compared here. The flexibility is high with basal bolus, can adjust for variable meals, whereas it is flexibility is low with premixed insulin, requires consistent meal timing, and the complexity is higher for basal bolus, multiple daily injections, that is 3 bolus insulins and 1 basal insulin, 1 or 2 sometimes, and the premixed insulin, it is they lower, the typically twice daily only. So we give biphasic premixed insulin only 2 times. There is a study called 1-2-3 study. Okay, the trial studied the 3 time the premixed insulin also. So you can also utilize that. Okay, so say morning, the afternoon, before the lunch or the before the night. 1-2-3 study. That is the study done 20-25 years ago. And the postprandial control is better with the basal bolus targeted meal time coverage, and it's moderate with the premixed insulin. The fixed ratio limits the optimization, and hypoglycemia risk can be lower with proper adjustment of in case of basal bolus. It is higher in case of premixed insulin if meals are skipped or delayed, or even the snacks are skipped also. You find that the incidence of hypoglycemia is more with premixed insulins. And the takeaways: the individualized treatment, stepwise intensification and frequent monitoring, and the patient empowerment. And coming to the case 3, it's a type 1 diabetes management, a case study. This case study examines a 22-year-old female with poorly controlled type 1 diabetes diagnosed at the age of 12. So when she was at 12, so the duration of diabetes is at least more than 10 years. So living in a semi-urban area with limited resources, she faced multiple challenges, including an inadequate insulin regimen and inconsistent monitoring, and the psychological barriers to proper self-care. An initial presentation showed very poor glycemic control with an A1C of 11.4, frequent glycemic variability, and early complications including mild diabetic retinopathy. So maybe it's NPDR, that is non-proliferative diabetic retinopathy. And nowadays we don't use the term mild or severe, it is NPDR or PDR. And the peripheral neuropathy. And this case demonstrates how appropriate medical intervention, education and support can significantly improve the outcomes even in the limited resource settings. So the patient profile and the initial assessment, the patient demographics and the poor glycemic control and the complications and the inadequate regime, and clinical challenges identified: inadequate insulin regime, two shots of premix, insufficient for type 1 diabetes usually, and lifestyle factors, and the limitations of the resources and the psychological barriers actually. These are the clinical challenges we can identify in a case of especially type 1 diabetes mellitus in a poor resource settings. The management strategy: insulin regime was changed, transitioned to basal bolus and NPH as basal insulin, regular insulin for meals, That is 6 units, 12 units in the morning and 8 units at the bedtime. That's what I told. So whenever you are using NPH, especially in type 1, it must be given twice a day. That is 12 in the morning and 8 in the night. And the regular insulin 6 units, 6 units and 8 units before dinner. See, always remember one basic funda, that whenever you are going for a basal bolus insulin or whatever it may be, so the prandial insulin, that is the bolus insulin must be 50% and the basal insulin must be 50%. Like you wanted to go for a 60 unit regime total in 24 hours. So the 10 units will be 3 times the prandial insulin 10, 10, 10, and the 30 units must be the basal insulin. Whether it is NPH or the once a day either glargine or the degludec. You want to give it in the analogs, you can give it 30 units at bedtime. And if you want to give the regular insulin, biphasic, the human insulins, so you can divide it into 3 times, like 10 units in the morning, 10 units before lunch, 10 units before dinner. The regular insulin for meal, and then the simplified carbohydrate counting. See, addressing the adherence and resource limitations, the psychological support and the gradual goals and the resource solutions and the technique improvement. So you can clearly see the 6 months outcomes in the bar diagram. The first one is A1C. There is little bit reduction in the A1C. And the fasting plasma glucose, you find a gross reduction. And the postprandial glucose also, there is a reduction but not considerable reduction. And the insulin adherence, it improved. And the hypoglycemic episodes are very much low. The key takeaways, the intensive insulin management, the basal bolus approach and the site rotation, this is mandatory for any insulin, site rotation and all. The proper timing is very important, and the dose adjustment. The lessons for resource limited setting, though creative adaptations and practical solutions and support networks and the incremental goals. And coming to the case for elderly diabetes management, preventing hypoglycemia. The diabetes management in elderly patients, they require a careful balance between the hypoglycemia control and the safety. So you should strike a balance between the glycemic control and the incidence of hypoglycemia. That is the main essence of it. This case study explores a 72-year-old male with type 2 diabetes experiencing frequent hypoglycemic episodes despite the near normal A1C levels. We'll examine how overnight glycemic control in elderly patients with comorbidities can lead to dangerous hypoglycemic events, and how treatment simplification and appropriate target adjustment can significantly improve the outcomes and the quality of life. What all we need is the quality of life. And the patient profile and the clinical challenges, we can see the 72-year-old male with the type 2 diabetes of more than 20 years of duration, the significant comorbidities, the hypertension and the chronic kidney disease, that is stage 3A. So the eGFR must be around 45 to 59 actually. History of mild stroke in the past and mild cognitive impairment. See, mild cognitive impairment we expect at the age of 70 and affecting the short-term memory. So it's not dementia or it's not the Alzheimer's, but it is the short-term memory loss with mild cognitive impairment. And the complex medication regime, that is insulin 70, 30 premix, 20 in the morning, 10 in the night, glibenclamide 5 milligram daily. This is the basic pitfall actually. See, the glibenclamide should be discarded actually. If at all you want to use it, you can use it until the age of 60 with maximum care. and once the patient touches 50, you should withdraw it. It's better not to go for the glucosamine at all, because it has got the serious hypoglycemic episodes, plus medications for other conditions. So there are so many medicines in his Pandora box. So he gets confused, and with a little impairment in the cognitive function, so he finds it difficult to the identify and take the medicines in proper time and the regular intervals, especially with insulin. The primary concern is the hypoglycemia. So this is the age, I said, we should be very cautious with the type 1 and the elderly patients. The young patients and the elderly patients, you should be very cautious with the hypoglycemias. Risks of overtight glycemic control in the elderly. See, overtight glycemic control is very important, but that should not be associated with hypoglycemias, especially in the case of elderly. So you can give some relaxations in the fasting plasma glucose and the postprandial plasma glucose, and even the A1C also you have some little bit of relaxation. If it is 7 for everybody, you can have a 7.5 to 8 in this particular patient. The cognitive decline, the falls and injuries are very important in this particular age group, and the cardiovascular events. The management strategy, regime simplification, the stop sulfonylurea, glucosamine, that's a dictum. So you cannot use glucosamine for a patient along with insulin who is around 72 years of age with the 20 years of duration. First of all, stop glucosamine, switch insulin type, adjust glycemic targets, implement a monitoring system. Dose titration and monitoring approach. Initial dose started with 18 units of glargine at night, holding off the mealtime insulin initially to see if basal alone could suffice given his low dietary intake, and weekly adjustments and the mealtime management and the family support. And the treatment outcomes, now the A1C is around the 7.8%. And hypoglycemia is 0, that is L3. Again L1, L2, L3 hypoglycemia. L3 is the severe hypoglycemia, L1 is the mild hypoglycemia, where the patient can help himself or herself. There is no severe hypoglycemia, as we have withdrawn this particular glucosamine, which is the culprit, and instead of the premixed insulin 2010, where we have introduced the basal insulin. So on the fasting is around 130 to 150, and the final glargine dose is 22 units. So relaxation, like for others it is 100 to 30, 80 to 130 according to the recommendations of American Diabetes Association as far as the fasting plasma glucose is concerned. But okay, in an elderly patient like 70 to 80, even 150 of fasting is acceptable. Even an A1C of 8 is acceptable. And key takeaways: avoiding the over treatment, the age appropriate targets, and the hypoglycemia prevention, and the simplified regime, and the caregiver involvement. The practical considerations for the elderly diabetic patients, that is individualized targets, hypoglycemia. See, all the time the diabetes care is customized and individualized. There is no universal counseling, there is no universal treatment. See, everything varies from patient to patient. The medication timing and the cost considerations and the home support. And coming to the case 5, managing recurrent hypoglycemia in a type 2 diabetes. So patient profile and the clinical challenges: 58-year-old female with 15-year duration of T2DM, and the current medication is metformin 500 mg twice a day, and premixed 70/30, insulin 30 units in the morning and 20 units in the evening, and glucosamine again 5 mg in the morning. So in India, we are tuned to this sulfonylureas actually. The older sulfonylureas like Glibenclamide is used extensively until recently. The government used to supply the glibenclamide and metformin only, and now of late it has stopped supplying the glibenclamide. Now it is giving glimepiride 1 mg or 2 mg with this particular metformin. That is at least a better molecule when compared to this with regards to the weight gain, the hypoglycemias and everything. And the recurrent hypoglycemias. The problem is recurrent hypoglycemias because of this addition of 5 milligram of glibenclamide. So, the identifying the hypoglycemia triggers timing mismatch. Insulin taken before coach and breakfast delayed by 2 to 3 hours, and medication issues, sulfonylurea increasing the risk of hypoglycemia, activity patterns, that is morning field work increasing insulin sensitivity, and irregular meal schedule, that is the carbohydrate heavy diet with unpredictable timing. These are all the barriers actually which trigger the hypoglycemia. The vicious cycle for the fear and the poor control, again the hypoglycemia episode and the hyperglycemia followed by again hypoglycemia, the fear development, the anxiety about the future episodes. Once the patient gets into hypoglycemia, the patient is very anxious, and the patient gets into a sort of phobia, insulin phobia, so that at any point of time I may get into hypoglycemia. That is the phobia, the insulin phobia, that is hypoglycemia phobia. And the defensive barriers, skipping the insulin doses and overeating. This is done by the most of the patients whenever they get into hypoglycemia. See the management strategy, the medication adjustments. The discontinue glibenclamide, adjust insulin timing, reduce insulin doses, consider future adjustments. And patient education, the cornerstone of the management. Hypoglycemia treatment protocol. Everybody should be taught the 15 the rule, that is the 15 grams of the fast acting carbohydrates, that is glucose actually, and recheck after 15 minutes. If repeated, you again give 15 grams of glucose, that is 15 bar 15 bar 15 formula. And meal and the activity planning and the regular monitoring and the family involvement. The family members should know how to tackle the hypoglycemia, the symptoms of hypoglycemia, how to counter the hypoglycemia. It should be taught to the family members. It's almost you should counsel the family all the time. Follow up and the outcomes, initial adjustments and the early follow up and the 2 to 3 months results and the long term plan. And after 2 to 3 months, the patient showed a remarkable improvement. Hypoglycemic episode decreased dramatically with no further blackouts. Her HbA1c increased slightly to 8 per 7.8. It doesn't matter. And an acceptable trade-off for safety. With restored confidence, she maintained the medication adherence and even lost 2 kilos of weight, unlikely from reduced defensive overeating. And the key take-home message is identify the hypoglycemia triggers first and try to avoid them. And second is patient education, which is very, very, very important. See, whatever you give, either insulin or the tablets plus insulin or the GLP-1 receptor agonist, whatever it may be, the continuous patient medical education is the cornerstone of our the management of diabetes care actually. And the safety first and the continuous follow-up. And coming to the last case, the overcoming insulin resistance in type 2 diabetes. The insulin resistance presents a significant challenge in remaining type 2 diabetes, particularly in insulin with obesity. The case study examines a 50-year-old female patient with a 14-year history of type 2 diabetes who demonstrate severe illness, severe insulin resistance despite high insulin doses, and will explore the comprehensive management approaches that successfully improved our glycemic control while addressing the vicious cycle of insulin induced weight gain. The strategy implemented include optimized insulin therapy, adjunct medications, and the targeted lifestyle interventions, and all tailored to our specific needs. That is, it should be, see, always remember, one size doesn't fit all. It is all the time customized, individualized, and personalized. It should be tailor made. There is no uniform size that fits all. The patient profile and the clinical challenges, the patient background and the diagnostic parameters and the current treatment. Metformin 1000 mg twice daily, the basal insulin glargine 60 units at bedtime. This is terribly bad, 60 units at bedtime. So you should not cross 40 units at any cost. The prandial insulin aspart 10 units before each meal. So three that is 30 units of aspart and 60 units of glargine. Losartan 50 mg, atorvastatin 50 mg. I don't think anybody is using losartan in their clinical practice. It has to be given twice a day because it doesn't cover the 24-hour period actually. The challenge of severe insulin resistance, the obesity driven insulin resistance, the high insulin requirements, and the vicious cycle and the treatment burden. The lifestyle and the weight management strategy, the calorie restricted diet. See, the problem with all the Indians, why they require insulin and huge doses of the OHS is because of the high carbohydrate intake. Take any part, whether the southern part or the northern part, eastern part or the western part or the central part of the India, around 65% is the usual carbohydrate intake in any given 24-hour day. So calorie restricted diet, supervised walking program, see modest weight loss. I always tell my patients ABCD, that's all. A stands for A1C, so keep it under control. And if it doesn't mean that, okay, you control diabetes, it is over. Not like that. Should control the diabetes, A1C, around or less than 7%. And a young patient fit to manage without any hypoglycemia, 6.5% is the target. And elderly people, it's around 7.5 to 8%. And second is B for blood pressure. All the time keep it in between like 120 to 130 systolic and 80, that's all. Nothing extra. And cholesterol, all the time keep this LDLC around 70 milligram per deciliter. And D is discipline. See, discipline is very, very important. See, timely breakfast, timely lunch, timely dinner, and the timely early morning, the timely late morning, the mid-morning snack, and the evening snack and the late night snack, and the timely sleep and timely exercise and timely drugs. This is called the discipline. That's what. That is very, very important. Always remember ABCD. See, optimizing insulin therapy and split basal dosing, divided 60 euglargine into 230 EU injections morning and night to improve the coverage. It's as very large single dose may have reduced efficacy due to poor absorption. That's what I said. Anything beyond 40 milligram, 40 units of basal insulin is hopeless. So what they have done is they have divided this glargine, because glargine also is not a true 24-hour acting drug actually. So in type 2 it's okay, because they have some pancreatic beta cell reserve, so that it may manage, it may pull over along the 24 hours. Now it can be stretched actually with greatest difficulty. But it attacks in type 1 patients, the maximum the duration is 18 to 22 hours, that's all. So the real insulin, what we find is the deglutide, that is the basal insulin with a very long plasma half life. That can be the best choice of the basal insulin actually. So even Glargine U300 is also at par with the deglutide. See, adjusted mealtime insulin and carbohydrate counting, and the adjunct medicines to combat the insulin resistance, that is they add the metformin, the 1000 milligram twice a day, because it's the best insulin sensitizer, and pioglitazone is the best insulin sensitizer when compared to the metformin. Pioglitazone added to the low dose 15 milligram daily. I advise you to go for only 7.5. Lower is more physiological as far as pioglitazone is concerned, and before putting pioglitazone to any patient, you should thoroughly screen the patient so that he is not volume overloaded, so that at any point of time a normal patient may get into acute heart failure. So that is the take home message for pioglitazone. Barring that, pioglitazone is the best drug till today. As of now, the 2025, the medications for type 2 diabetes, they published by American Diabetes Association, says pioglitazone is the best molecule, barring the patient selection. If you have a right patient, that is the best medication, and the lower is more physiological. There is only one molecule, I think, in the country with 7.5, that is USV people have it with the brand name of PIOZ 7.5. If it is not contraindicated, you can always go for pioglitazone, but try not to combine insulin with pioglitazone, because both of them may precipitate acute heart failure. So the medication, they added a low dose to improve insulin sensitivity with the careful monitoring for fluid retention. See, the fluid retention, the basic mechanism in pioglitazone is that transfers the visceral adipose tissue to the peripheral adipose tissue. That is the reason why you find the pedal edema in case of the pioglitazone. And the medication review ensured no other medications were contributing to insulin resistance, and GLP-1 receptor agonists. See, these are the promising drugs, but they are very costly. For Indian scenario, we cannot afford to go for that. At least the weekly injections have come from liraglutide to semaglutide to even the tirzepatide. The best out of all is the tirzepatide, because it has got the dual way of mechanism. Not only the GLP-1 receptor agonist, it is GIP receptor agonist also. All others, they act only on the GLP-1 receptors. See, weekly once injection, somewhere it is around 4 to 5,000. So a month cost will be 20,000, apart from the insulin you use, apart from the SGLT2 inhibitors, apart from the metformin, apart from the DPP4 inhibitors, whatever be the drugs you use for that particular patient. So GLP-1 receptors have got the maximal the benefit against the 3-point MACE. Actually, the atherosclerotic cardiovascular disease is well prevented by these GLP-1 receptors and the SGLT2 inhibitors, especially when it is related to atherosclerotic cardiovascular disease. GLP-1 receptors, they score much, and when it is related to heart failure and the hospitalization for the heart failure and this SGLT2 inhibitors, they play a vital role. And monitoring and support system, enhanced SMBG protocol. See, everybody should be encouraged, all the patients should be encouraged for the self monitoring of blood glucose. So also the home blood pressure monitoring actually, which gives you the best results. See, you can rule out white coat hypertension and the masked hypertension when you monitor the BP at your house actually. See the clinic one time reading may be excessive. Sometimes the white coat hypertension, and you may miss the masked hypertension also. These are covered by this, and biweekly check-ins and the positive reinforcement and multidisciplinary approach. The outcomes and key takeaways: the weight loss was 5 kilos, the improved A1C it was 8%, and reduced insulin to 70 units. And this case demonstrates that even in resource constrained environments, addressing the insulin resistance through weight management, optimized insulin regime, and the adjunct therapies can break the cycle of the treatment resistance. The patients improved glycemic controls, reduce medication burden, but it increases the cost burden because aspart is costly as well as the glargine is costly. These are all analogs. So if the patient is able to go for the analogs are the best insulins. The patient is not able to go for analogs where the purse doesn't allow the patient to go for analog insulins. He can even go for the genetically or engineered DNA, the biphasic premixed insulins, or the NPH, or the regular insulin. So these are also they prove to be much better. Only thing is you need to counsel the patient to reduce the carbohydrate content to avoid the weight gain, and the frequent snacks to avoid hypoglycemias. These are the two points between this, and only thing is it has to be taken the regular human insulins, the biphasic or the NPH, they have to be the not NPH, the other regular and the biphasic premixed human insulins are supposed to be taken 30 minutes prior to the each meal, because it is in the form of hexamer. Hexamer has to break down to dimer. Dimer has to break down to monomer. Monomeric insulin is the active principle of the insulin. So that takes around 30 minutes time. Whereas these, the analogs and all, they are in the monomeric form. So the moment you give the before food it acts, even you forget in the middle of the your food you can take it. Even you forget after the food also you take, it works. I don't mean to say that take it after food, take in between the food. Then you always try to take at least 5 minutes prior to the food, even the analogs also. Even in case you miss also, the greatest advantage is you don't need to wait for 30 minutes. And the weight gain is compared to this the human insulins, it is very low, and the incidence of hypoglycemia is also very low. These are the greatest advantages of the analogs. And high sugars, low insight.
Thank you so much.
Insulin alone isn't enough when education is missing. And thank you for patient listening. And if you have any questions, please can you check the chat box if there are any queries, questions, so that I can take up, ma'am.
Can we have a straight away instead of putting on the chat box?
Yo, Rajdeep, welcome Rajdeep.
Yes, there's a fundamental question I need to ask you in this presentation.
Yeah, please.
Yeah, this is regarding especially on the case 1 and case 2. I'm not talking about the case 3 because I think type 1 did that.
Yeah, type 1, yes.
So, looking at the present guidelines and looking at the insulin regime,
Yeah.
right, and the kind of OHA these patients were there, right?
Yeah.
And before initiating the insulin, we have certain untapped diamonds in terms of an OHA. Shouldn't we have started those untapped diamonds before switching over to the insulin regime?
Yeah,
and
that's...
you being the master to bring the A1C from 11, 12 to 7.1 with the OHA on.
Rajdeep.
Nowadays.
Yeah, Rajdeep is my... he is my best friend. He is my classmate. We way back in '82 we joined the medical school. So I told I told in the beginning itself, Rajdeep, he is only on two drugs. You can as well go for the SGLT2 inhibitors. The first case was only he was on 2 grams of metformin and 8 grams of glimepiride. He was on only 2 drugs. He never tried to go for the latest drugs. These are all the older drugs. See, they could have gone for this particular the SGLT2 inhibitor, either the empagliflozin or the dapagliflozin would have served the purpose without even going for insulin. See, once the dictum I told you is either the patient should be on 3 oral drugs, the untouched molecules, the latest molecules, or the patient A1C is even after 3 drugs, if it is more than 9% of A1C, then that is the indication for insulin. That's a wonderful question. There itself I had clarified, Rajdeep. They have not tried this particular third drug, and without that they straight away had gone to insulin.
This is in context to Indian patient, Krishna. Nobody likes to go for an injectable. Second thing, I mean, they try to avoid. Second thing, when we have so many untapped diamonds in terms of OHA.
Yes.
Third thing, we need to start those OHA where we cannot need to frequently monitor KFT, LFT.
Yeah, that's what. I always say after metformin, you only try this triple combination, metformin and empagliflozin and linagliptin. That's all. A drug naive patient or a newly diagnosed type 2 diabetes patient, this combination holds good, and you don't need to monitor anything at all.
Yes, with linagliptin we don't need to monitor.
Yeah, linagliptin is the real gliptin that can be used in any stage of the CKD, any stage of DKD, and with any figure of EGFR, Rajdeep.
Yes. And second question, who is prescribing glucosamine? We need to go with the glycoside now.
Yeah. See, I told avoid glibenclamide first of all. Discard glibenclamide from the armamentarium of your diabetic drugs. And second thing is glycoside modified release or the extended release is the best one, and followed by the glimepiride. That's all. These are the 2 ones you can. And if the cost is the biggest barrier, you can go for glipizide actually. Glipizide 5 milligram BD is as good as any other drug actually. And to control the uncontrolled fasting plasma glucose, glipizide is the drug of choice. That is the greatest advantage of this particular the molecule, the glipizide. That is the 1 rupee product. See, when the affordability becomes the big question, we can go for this particular the glipizide. If the patient is able to go for this affordable ones, my first choice would be the glycoside modified release or the extended release, followed by this particular glimepiride. These are the best molecules to start with, along with metformin, and then go for an SGLT2 inhibitor.
Yes,
Yeah.
So add linagliptin, any gliptin also.
Gliptin also. Though gliptins, they are neutral to except saxagliptin, all the gliptins are neutral to this particular cardiovascular safety. But to some extent, the Carolina have proved when compared to the glimepiride, the linagliptin has shown to be little bit more cardiovascular, pro-cardiovascular actually. So linagliptin is the best, EMPA or DAPA is the best, and this if at all you want to use sulfonylurea, you go for not the glibenclamide. You totally avoid glibenclamide, and you keep this glipizide as reserve for the poorest of the poor, like Walmart, Rajdeep. Walmart and McDonald's. Poorest of the poor go for McDonald's and the Walmart. But in the US, but this is a different scenario in our country that they feel proud to say that I had been to Walmart, I had been to McDonald's. Just like that. And the glycoside and the glimepiride are the best ones. If at all you want to go for secretagogues.
Second question, Krishna.
Yeah.
What is the starting dose of pioglitazone? It's a very good sensitizer. Is it 30 or 15? Or
See, I would rather go for initial will be 30.
Right.
30 single dose.
1 month.
1 month, maximum by 2 months. And after that I come down to 7.5, Rasdeep.
Okay.
It's an invaluable drug actually. Invaluable drug at a very economical price. But that is often underused because of the pharma industry only. That's it. Okay.
And of course, the patient selection criteria should be there.
Yeah, I told you when I showed you the slide with 15 milligrams. I said even 7.5 is reasonably good to start with. Even you don't need to go for 15 also, because the patient selection is very important. The volume overloaded state is the biggest contraindication for this particular the initiation of pioglitazone. And there are the two conditions wherein you need to go for the highest doses of pioglitazone. One is the MASLD and second is the PCOS, where 7.5 is not going to be worthy enough. But for the management of diabetes, it is exceptionally good. Whereas the MASLD, that requires at least 45 milligram. Maximal dose of pioglitazone is required to reduce the reversal.
So you mean to say after 30, maximum 1 to 2 months, we come down straight to 7.5?
Yeah, absolutely.
Okay. And one last question.
Yeah, please, any number of questions. I forgot to welcome Rasdeep in the beginning. I should have welcomed.
One more question.
Yeah, tell me, Rasdeep.
There is a misconception among the so-called educated class in the Indian society that let's avoid the diabetic medicine, go for a calorie restriction.
Yes.
And though they have a tendency to go into, they say no, we have tendency, we eat food, we go into the postprandial hyperglycemia. So they try to avoid the food. Please.
So, yeah, nowadays the calorie restriction or the reversal of diabetes programs have increased drastically by non-medical people.
Yes.
Intermittent fasting for a period of 18 hours, which is terribly bad. They land up in heart attacks and paralysis all of a sudden. So that is not at all advisable, and reversal is possible. I don't say it is impossible, but initially you cannot afford to go for that particular reversal process. See, once you are so motivated, like you go for 5 to 10 kilometers of walking and a calorie restricted diet along with the medicines, in due course you may I have got hundreds of patients, Rasdeep, to tell you. They just come and have a check once in 2-3 months. They are not on any drugs. Initially I had put them on metformin, and olden days, like 30 years ago, I used to put them on only metformin, maximum dose, and slowly reduced to the started with 500 to 2 grams, again reversal 1500, 1000 and 500, stopped. Everybody is doing well. There is no cure for diabetes, it's only a reversal stage.
So that's with the lifestyle modification.
That is with the lifestyle modification, not with the drugs. Reversal is defined as if you can maintain the normal fasting plasma glucose and the 2-hour post plasma glucose and the A1C without any medications, with lifestyle modifications especially. That is the diet and the exercise, the weight reduction, cessation of alcohol, cessation of smoking. They hold good, Rajdeep. That's a valid question what you have asked. See, everybody is running after the non-medical people who are conducting classes, taking thousands of rupees as consultation fees. That is one way of the modern business. I think they are making out of it.
That means you were able to even stop metformin also.
Yeah, we can stop even metformin also. The
One in 10, 1 in 100. I'm just trying to understand in terms of figure. How many patients you were able to stop the?
Probably 1 in 100, Rosli. Probably.
Okay, got it.
1 in 100 or 1 in 150. Not that common. It's very difficult actually. The lifetime, the patient, he or she should have the lifetime motivation. See, why even after the metabolic surgeries, you take the gastric bypass, the lap sleeve gastrectomy or Ruvayan gastric bypass, why there are a lot of failures? It is because of the initial the lifestyle modification. Later on, they don't go for lifestyle modification. Again, they reduce to 50 kilos, they gain 70 kilos. Even the metabolic surgeries, earlier we used to call them the bariatric surgeries, are also becoming failure because of the lack of motivation from the patient side, Rajdeep. That is the most important point actually. Whatever it may be, any chronic disease, the metabolic disease, the lifestyle disease, it should have the lifetime lifestyle modification. Am I right or not, Rajdeep?
Of course, this is my, this is a question from hundreds of patients.
That's what.
Who says that I'll skip the dinner?
No, that's see, skipping dinner, skipping breakfast is as bad as anything. You cannot skip your meal actually. See, you can restrict the calories, reduce the carbohydrates, but at the same time you can never skip the meal. That leads to hypoglycemia definitely. The irritability, they cannot concentrate on the work, day-to-day work. Lot of difficulties, and it is, to tell you very honestly, the evidence-based medicine says if you skip a breakfast, the patient is at risk of getting heart attack by 27%.
Oh, I see.
Skipping breakfast, the International Diabetes Federation, where I'm a special invited and speaker, chairperson, so many things. So it says always the healthy day begins with a healthy breakfast. Healthy day begins with a healthy breakfast. If you skip a meal, so you tend to get into heart attack straight. The incidence is 27%. It is very huge actually. So taking in moderation is the best policy, Rajdeep.
Got your point. Because this is a question which is being asked by hundreds of patients.
No, because all the quacks and all the people who want to make money out of this diabetes, they have diabetes chappals, they have diabetes rice, they have diabetes sweets, they have diabetes atta. Like this, no diabetes, again, reversal.
Yes.
And they collect fees for that. we are underpaid, Rajdeep. After 32 years, I take 300 rupees.
Krishna, one thing, you never talk about AGI.
Yeah. See,
You know why I'm asking this question? Postprandial hyperglycemia is the biggest culprit in
yes,
type 2
yes. See, nowadays what has happened is they are looking at the cardiovascular safety. As far as AGIs are concerned, they are not cardiovascular safe. Outcomes are not that good. And second thing is, indirectly by reducing the postprandial excursions, the glycemic control itself is going to control the cardiovascular events. So in that case, a normal fasting plasma glucose with an abnormal postprandial excursion is an indication for alpha glucosidase inhibitor. Your choice may be acarbose, my choice may be oglibose, whatever it may be. They are valuable, invaluable drugs whenever the post lunch is high. And that too, I always tell everybody in my every program that a normal fasting plasma glucose with an abnormal postprandial excursion in type 2 diabetes is associated with a very high incidence of cardiovascular events, either the heart attack or the strokes. The largest study being the Honolulu study. There are major 7 studies, and the largest is Honolulu study. You know, you reside in US. Honolulu is the 50th state, that is an island in between the US and Japan. So Honolulu study says very clearly that the abnormal postprandial excursions, which are well controlled by AGIs, is the biggest cause for heart attacks. So in that way, you control this postprandial excursions by putting 1 tablet of oglibose or acarbose, whatever it may be, 25 milligram or this 0.3 milligram. So you start with 1 tablet in a week. A second week you start the second tablet, and if it is required you start the third week the third tablet on the night also. But the only thing is it has to be taken after the first bite of meal, whatever it may be, breakfast, the roti, idli, sabji, whatever it may be, you take the first bite, then wait and take this tablet, then continue your meal. That is the only way how it works well.
It's Asian phenotype.
Yeah.
Normal fasting, normal A1C, and abnormal PP is a very common scenario.
Very, very common scenario. In that case, the most valuable drug is the alpha glucosidase inhibitors. And I have listened to somebody else saying, very unfortunately, I saw the prescription with AGI. See, it's a ridiculous statement actually. Ridiculous statement. He said, I don't want to name anybody else. One gentleman says, very unfortunately, that was a very unfortunate day for me to see a prescription which has got AGI. What is wrong with AGI? I still don't understand. Okay. See, when you have abnormal postprandial excursions, that is the only drug which controls that. And even the best part of SGLT2 inhibitors is the EMPA or the DAPA, especially the EMPA. EMPA controls the postprandial excursions in one single day, Rajdeep. I am all telling the evidence-based medicine. See.
Can we combine AGI with the EMPA?
Yeah, can be combined. The greatest advantage of all these molecules, they can be combined with all the molecules like metformin, the sulfonylureas, or the pioglitazone, or the DPP4 inhibitors, SGLT2 inhibitors, the AGIs. They don't have any interactions at all. Drug to drug interactions are not at all there for all these molecules. And the greatest advantage of this the SGLT2 inhibitor empagliflozin is within 24 hours you can see the drop in postprandial hike. Apart from the benefits what it has got.
Thank you, Krishna. And last one suggestion. Is it not time for you to revisit the diabetes guideline in context with Indian phenotypes?
Rajdeep,
and gliptins, all those.
ADA will sue against me.
I think only you.
Indian scenario, Indian phenotype is totally different from that of the Caucasians.
Yes.
As far as diabetes is concerned. For example, I will tell you, the DPP4 inhibition is more in Indians when compared to the Caucasians. So, the reductions in the A1C is more in Indians when you use any DPP4 inhibitor when compared to the Caucasians. Likewise, there are several studies done in Japan, in India, and China, all the Philippines and all. They have shown the very low, the very high reductions in the A1Cs. Likewise, the SGLT2 inhibition is also more in Indian phenotype when compared to the Caucasians. So these are all the benefits. These are, see, Indian diabetes phenotype is totally different from that of the Western scenario, Rajdeep. So it's a high time we should have our own guidelines and our own this thing. Let us not follow them like just.
I don't follow ADA. I follow only KDA. Very frankly, even my ADA colleagues just say, "What the hell I'm talking about?" But
KDA.
They don't know whom I am representing.
Krishna Diabetes Association.
Thank you, Krishna. Sorry, I took a lot of time.
No, it's a great pleasure seeing Rajdeep. That's what.
Thank you. You're a Pandora box.
Thank you, Rajdeep. Thank you. Any other questions, please? Ma'am, if there are no questions, shall we wind up this session?
Yes, sir.
Yeah, please, ma.
Thank you so much, sir, for your insightful session.
Thank you, ma. Thank you so much, ma.
And gave your precious time.
Yeah. Pleasure is mine.
Information.
Pleasure.